All right, you guys, welcome back to the channel. Dr. Jimmy here, and I'm a clinical pharmacist. First of all, I want to tell you guys, thank you so much on all of the love you guys showed me on episode one. If you haven't watched it, episode one is right here. I really want to keep this going, and then this is the second episode. So if you're new here, I basically break down these medical TV dramas from a pharmacist perspective, from a drug pharmacology perspective, on why drugs are given in clinical scenarios. And so, man, again, to a small channel like me, all of those views, it means a lot. I was not expecting all those the views to accumulate. And so, which tells me you guys like this type of content. And if you do, keep dropping a like, keep dropping all of the support. And then let's move along, to episode two. So without further ado, let's get it.
Nick Bradley, 19, found unresponsive by parents. No meds, no allergies. On arrival, he was barely breathing with pinpoint pupils, bradycardic at 38.
Pupils responded to Narcan, but we tubed him when his respirations didn't pick up.
Any drugs or alcohol on the scene?
No,
Signs of trauma?
nothing.
Okay, open your eyes, Nick. On three. 1, 2, 3.
Where was he found?
In bed by his mom.
Pupils are 6 millimeters, non-reactive.
Heart rate 64, BP is cycling. No response to pain, GCS3.
Does that fit any toxidrome?
No. If it was just opiates with Narcan, he'd be breathing on his own.
Beta blockers shouldn't give pinpoint pupils.
Maybe parents had some prescription meds in their bathroom.
They're on their way.
All right, so here is a good scene that I want to stop and educate you guys on what's going on with this young patient clinically, what's going on right now. And so you have a young patient, he is 19 years old. So EMS brought him in. He was unresponsive. He was found in the bed with his parents with pinpoint pupils and a significantly low heart rate. His heart rate was in the 30s. So that's medically termed bradycardia or severe bradycardia, borderline dead, basically. And so with this patient here clinically, we just don't know what's going on. And so given what the EMS person told us, all of these things, found unresponsive in bed by his parents, pinpoint pupils, severe bradycardia, he did not have good respiration, so they had to tube him along the way, and they gave him Narcan. And so what this points towards is something called opioid toxidrome. And so just to be clear, there are multiple forms of toxidrome that can exist. You have beta blocker toxidrome, you have anticholinergic toxidrome, sympathomimetic toxidrome. It's so many different toxidromes that can happen. But the hallmark with this patient, with this clinical presentation on arrival from the EMS, they said that he had pinpoint pupils and he has severe bradycardia, and they gave him naloxone, which he responded to briefly, but it didn't do anything. And so all of these are telltale signs that points us towards opioid toxidrome, rather any other type of toxidrome. It's not 100% diagnostic of opioid toxidrome, but it points us toward with a high suspicion of opioid toxidrome. And so the medication that was used here is called naloxone or Narcan. And I think this is very appropriate for this scene here, simply because as the EMS people bring him in with the emergency medicine personnel, all of the trauma people, what they're doing is they're trying to get some sort of reflexes out of him, get some sort of response out of him. And from the outside looking in, the EMS people brought him in. We simply don't know how long he was down. We don't know how long he had this toxidrome going on. We don't know how long he has been in overdose. And so they gave him Narcan once. We only heard that the EMS person said they only gave him Narcan once, no other time. And so what that tells me as a pharmacist is this patient brought in pinpoint pupils, only gave Narcan one time. You can usually give Narcan in repeated doses, but he did not respond well to the Narcan. He responded briefly, but then again, his respiration decreased again. Therefore, they had to tube him. And so the way that Narcan works is that your body has mu opioid receptors. And these mu opioid receptors are targets for your opioids like fentanyl, oxycodone, oxymorphone, hydromorphone, hydrocodone, Percocet, Vicodin, morphine, cocaine, heroin, things like that. These are very, very pure opioids that will absolutely bind to those mu opioid receptors and cause significant respiratory depression, significant bradycardia, significant CNS depression if abused, if dosed incorrectly, right? So all of these things here are blocked and mitigated by naloxone. Naloxone competes with that same mu opioid receptor, but instead of activating those mu opioid receptors, naloxone blocks those mu opioid receptors. It blocks those opioids from binding to that specific binding site, therefore reducing all of the opioid-like effects. And so naloxone is used specifically in the emergent setting, right? And so I don't want people to get confused with naltrexone. Naloxone and naltrexone are two totally different drugs chemically. However, they do the same thing. It just depending on the situation. The emergency situation, naloxone is certainly the drug of choice, given the pharmacokinetics, given how fast it comes on. So given the amount of routes that are used to give the medication, you can give the medication in so many different ways in the emergency setting. You can give it IV, you can give it intranasally, you can give it intramuscularly, you can give it subcutaneously, you can give it in so many different ways that favors the use of naloxone over naltrexone. Naltrexone is just a chemically different version of naloxone that is intended to be used to prevent relapse, to treat opioid withdrawals long-term maintenance. And so this is not something you would certainly use in the acute phase in the emergency setting. It has a significant long half-life over naloxone. And so I just want people to understand that naltrexone and naloxone are two totally different drugs, but they are the same drug in a way, right? I know it's confusing. They are the same drug, but chemically they're different to do different things in different situations. So naloxone is very, very appropriate. As a pharmacist, I like this scene. It fits the clinical presentation. Now, if you guys notice that from arrival, this patient clinical status changed that quick. You guys might not have caught on to it, but his clinical status changed that quick. EMS people brought him in. He had bradycardia, low heart rate, all the way in the 30s. His pupils were pinpoint, and then they gave him naloxone, in which case he responded, but then his respiration decreased again, so therefore he had to tube him. The resident just checked his pupils, right? She just checked his pupils and said that his pupils are 6 millimeters dilated, unreactive. That's very important, and it tells us as clinicians, as pharmacists, as nursing staff, residents, it tells us a lot of information in this short period of time, what's possibly going on with this patient. This patient, again, we don't know how long he's been down. We don't know how long his brain been without oxygen. And so this tells us that because his pupils are dilated and unreactive, something is wrong with his cranial nerves. His cranial nerve that controls a lot of things in his brainstem, it gives us a significant viewpoint inside of what's going on clinically with this patient. And so he has a GCS of 3. Now, a GCS is simply an objective way to determine how severe your impaired conscious is, right? We want to see how impaired a person's conscious is, and your GCS or Glasgow Coma Scale just tells us the severity of that. And so 3 being the lowest and 15 being the highest. This patient, GCS, was noted by the resident that he had a GCS of 3. Now, GCS of 3 is the worst possible GCS you can have. And what this tells us is that he has a very, very poor prognosis. He's basically in a coma, no motor reflexes, no pupillary reflexes. He don't have anything. And so this is very bad. And so I don't know if he's going to survive or not. I highly doubt he's going to survive, given that we just don't know how long he's been without oxygen. He has a GCS of 3. Hopefully he can pull through, but as a pharmacist, I do like this scene. The drug was appropriate for the clinical presentation. However, they never say dosing. They could have just said give naloxone X amount of dose, but in real life, I do like this scene, and I think it's very appropriate here.
No blood in the belly, no pericardial effusion, and lungs are up.
Hemo Q's good, 15. BP 84 over 58.
Okay. What's your plan, Dr. Collins?
Push dose epi, 0.1 milligram, Foley for urine, stabilized for CT. and throw a wide net.
All right, so I do want to stop here, and I'm glad that they have this scene in quick succession of the other scene. And I love this scene for several different reasons. And so let me break it down to you guys and see what's going on clinically in this scenario with the patient. And so given what we already know with the patient now, he has a GCS of 3. He don't have any brainstem reflex. And so you hear that the physician asked the resident on what's her plan. And so she wants to start a push dose epi, okay? Push dose epi or push dose epinephrine is so important in this context here with this specific patient in this clinical scenario in the emergency setting. And so to understand this, it's very, very vital to understand what a push dose epi is. So let me explain. Epinephrine, which is the drug of choice, is a vasopressor, a very, very potent vasopressor. And so epinephrine is usually dosed in micrograms, not milligrams. It's only dosed in milligrams in certain scenarios, in certain disease states. For example, cardiac arrest. If this was a code and this patient had no pulse in cardiac arrest, then you would go with epinephrine 1 milligram. Epinephrine is usually dosed in micrograms if we're giving it as a continuous infusion. And so here she said 0.1 milligram. As a pharmacist, this shit makes me geek out. You speaking my language, you turning me on. I love when TV series include the dosing because this is very spot on. She said 0.1 milligrams of epinephrine or push dose epi. And so why do we use push dose epi in this situation here? So this patient here has a blood pressure of 84/58, I believe. And so to prevent this patient's blood pressure from going down further or crashing, and so she wanted to start a push dose epi in order to stabilize or just slightly increase the blood pressure, just in time for her to get a definitive vasopressor started as far as what you want to do. So typically it'll be a norepinephrine or levofed drip. And so, but that takes time to get approved by pharmacy. That takes time to set up in the ER in an emergency setting. You need the available nursing staff. That just takes time, and that's critical time that we need for this patient to stabilize. And so push dose epis are very, very important. And this is the perfect scenario to use a push dose epi when a person's blood pressure is not stable or leading towards crashing. And so she's just trying to prevent his blood pressure from falling even further. And so depending on your hospital's protocol, depending on your physician, depending on how people think, I'm okay with the push dose pressor, or I'm okay with giving fluids to see how this person responds, right? You want to give fluids to see how he responds initially, recheck his blood pressure like in about 15 minutes, just to see how this patient responds. And so if you pay attention, the blood pressure was 84/58, I believe. And if you do your calculations, he is currently at a gold MAP. MAP stands for mean arterial pressure. And so the standard recommendation for like your MAP perfusion level is usually over 65. And so this person's MAP, he's actually doing good. And so one would argue that you don't need a push dose epi here, but again, this is very situational depending on the physician. So I'm okay with either or. So let's dive deep into the push dose epi. So epinephrine as a drug is very potent, like I said earlier. And so the mechanism of action behind this is that epinephrine, it exerts its effect on multiple different receptors. You have beta receptors, you have alpha receptors. And so epinephrine, being the vasopressor that it is very potent. It activates those beta 1 receptors that are located in your heart. It activates those beta 2 receptors that dilate and open up those lungs. It activates those alpha 1 receptors that squeeze those blood vessels, those arterioles, in order to increase the pressure in those arterioles, to increase the blood pressure. And so epinephrine is very potent. It's not really selective. It activates all of these receptors to high affinity. And so push dose epi, again, is very important. I want to stress this. The dosing is so important because she said 0.1 milligrams and not 1 milligram. 1 milligram is cardiac arrest dosing with patients without a pulse. This patient clearly has a pulse, and so you want to give 0.1 milligrams. How do you achieve this? And so this is why pharmacists are so important in this situation. This is our bread and butter, pharmacology. dosing indication. So certainly a pharmacist would be here, right here in the scene, but typically medical TV series don't really show pharmacists, but I guarantee you in real life, we will be here right in this ER room, right there with the physician, mixing any type of drugs, dosing any type of drugs right there. And so in order to achieve this push dose epi dosing, you need to take 0.1 milligrams, right? And which is 1 milliliter out of that cardiac arrest dose. That's 1 milliliter. And then you take 1 milliliter of that, and then you take 9 milliliters of normal saline. Okay, you have 9 milliliters of normal saline, 1 milliliter of that cardiac arrest dose, and then you infuse it, you mix them together. Now you have 10 micrograms per milliliter. Okay, micrograms, not milligrams. And this is very important because your cardiac arrest dose is 1 milligram. Your push dose epi dose or concentration that you start with is 0.1 milligram. And so after we mix it, it becomes 10 micrograms per milliliter, which equals 100 micrograms total. And so microgram is 1,000 times smaller than milligram. I need people to understand this. And this is why a pharmacist is there, because your conversions matter. Okay, just imagine, right? You're supposed to give someone 1 milliliter or 1 milligram of something, and you end up giving them 1,000 milligrams of something. Do you guys see how much of a difference that is? And so epinephrine, again, is usually dosed in micrograms in most indications. Certain indications warrant the use of milligrams, which is your cardiac arrest dose, and certain type of anaphylactic reactions. And so I like this scene here is very, very spot on, depending on your hospital's protocol, depending on the physician, depending on, it's just so many thought processes and variables, but push dose epi is certainly appropriate in this situation. I'm okay with either way to prevent this person's blood pressure from dropping even further. She's wanting to prevent that. And so that's why she's giving the push dose epi in this situation. Depending on your hospital, again, I say this a lot because it varies. There's no standard of care. Hospitals typically will have either phenylephrine. Phenylephrine is different from epinephrine, okay? Phenylephrine, this is a pure alpha-1 agonist. And so what a pure alpha-1 agonist is that it only activates those alpha receptors, specifically alpha-1 receptor. And recall, those alpha-1 receptors are your arterioles. So it squeezes those arterioles in order to increase the blood pressure. No effect on beta receptors, no effect on beta-1 receptors, no effect on beta-2 receptors. So it doesn't play a role in your increased chronotropy, increased inotropy, or so your increased contractility. It doesn't do anything with the lungs. And so phenylephrine is different from epinephrine. Both are very potent, but phenylephrine is more selective for the alpha receptor. And so hospitals typically will have pre-filled syringes of phenylephrine, not epinephrine. Usually we have to mix epinephrine, push dose epi. But phenylephrine usually come with already pre-filled syringes. And so I love this scene so much for so many different reasons, but that's the main reason. The dosing is very spot on. I do like the indication because this is a perfect scenario where you could use push dose epi. Again, you can also give the patient fluids to see how he responds, but the patient is already quote unquote brain dead from hypoxemia. And then we just don't know how long he's been without oxygen. He doesn't have any pupillary reflexes. He don't have any type of brainstem reflexes. He's GCS of 3. He has a very, very poor prognosis right now. And so I understand if someone wants to give him a bolus dose of fluid to check his blood pressure, then he has a current map that is acceptable. So I need people to understand how important this scene was, and hopefully you learn something from this scene. Push dose epi is very different from different indications with epinephrine, okay? It's super important, right? It's dosed in micrograms, not milligrams. So I think this scene is very appropriate.
Systolic back down to 90.
Another 0.1 of epi.
Flaccid paralysis of all 4 extremities.
No eye movement with ice water.
So no brainstem function.
Due to?
Hypoxic injury, massive hemorrhage. Samara, escort him to CT. Take the drug box with you.
Call me if you need me.
And so I did wanted to stop here at this scene as well. Again, this is another scene happening in quick succession here. Everything I said about the previous scene, I love, I like, but then I get to this scene here and it's questionable here. And let me explain why. And you see that it's the same patient. And so both residents are doing their, exams to evaluate brainstem function to try to get a response from this patient. And you hear that she wants another 0.1 of epi. You hear her specifically say another 0.1 of epi after determining that the blood pressure is now 90. Okay, it was 84 previously, and then she gave the push dose pressure, and now it's back down to 90. And so here they've been in the ER long enough to get a definitive vasopressor drip started. Right, push dose epis are not supposed to be indicated back to back to back to back in order to treat the underlying condition, right? And so that's why vasopressors are there. Push dose epis are served as a bridge to get your patient to stabilize on definitive care with that vasopressor. And so I don't really like this scene here because first of all, she said another 0.1 of epi. Typically in the hospital, we don't refer to it as another 0.1 of epi. We would definitely say push another 5 to 20 mics. Okay. Once you made the dilution with the push dose epi, you've made the 0.1 milligram, which is the 1 ml of the cardiac arrest dose, and then you dilute that in that 9 milliliters of normal saline. You have your final concentration in a 10 milliliter syringe. And so going forward, we would have said, hey, push another 10 mics, push another 5 mics, not another 0.1 milligram. So I think the editors here just was a tad bit off with that, with the actual, what we do in real life, not 0.1, because how do you measure 0.1, right? And so 0.1 milligrams. And so right now, she's already mixed the drug. It's already diluted. And so now we refer to it as micrograms or mics is what we call it in the hospital. So push another 5 mics, push another 10 mics, so on and so forth. And so again, this patient's blood pressure is really stable. Again, it's in the 90s. It's really okay. Okay. So it went from 84 to 90. So it's okay. I would have liked for this person to have definitive vasopressor therapy because this patient has been in the ER long enough for us to either grab it out of the Pyxis machine or get it from pharmacy. Like they have plenty of time to grab a vasopressor drip and get it started on the pump and things like that. And you also see here that the resident in black, she said that he has flaccid paralysis in all 4 extremities. This is very important, which reinforces our knowledge and reinforces our suspicion and clinical diagnosis of this person has a severe brainstem injury due to whatever reason, right? They still haven't figured out the reason, but because this person had an opioid toxidrome, he has no brainstem reflexes. And so when you have flaccid paralysis, and then you see that the resident with the red shirt, she pushed ice water into his ear. All of these are a diagnostic workup to point us towards brainstem, loss of brainstem function. And so this guy, he has no brainstem movement. And the thought behind it is if you push ice cold water in a person's ear, your pupils should react, which tells us that your cranial nerves, things that control your eye movement and all of your neurologic functions are intact, or at least somewhat intact and not severely damaged. And so with here, ice water pushed into the ear, flaccid paralysis in all 4 extremities, this definitely tells us that this person has a severe brainstem injury, likely due to hypoxemia, which is low oxygen to the brain because of his opioid toxidrome, because of we don't know how long he's been down. And so with this scene here, I don't know. Again, depending on your hospital's protocol, depending on the ER physician and the ER team, some people will definitely give another push dose pressor, or some physicians would like to give a definitive vasopressor started because of the allotted time that was spent on this patient. They definitely had the time to set up a norepi drip or levofed drip. And so with this scene here, I think it's okay. I'm not with it, but I'm not against it either. And so I think it's okay. And that completes episode 2, you guys. And look, you guys have shown hell of a lot of love to me on my first episode. I was not expecting to get a lot of likes like that because I have a small channel and like over 1,000 views in like that amount of time. It's like massive. So man, keep dropping the likes, keep dropping the support. I'm trying to crank out these videos as fast as I can with my time allotted. And again, this is from a pharmacist perspective, a drug pharmacology perspective on why drugs are given in clinical scenarios. So without further ado, if you have any questions or concerns, if you learned anything, drop it in the comment section so everyone can know what you're thinking and things like that. And so yeah, keep the support going, like, comment, subscribe, and I'll let your boy.